Start. First of all, thank you so much for coming today from all over the world, all different time zones to join us. It's incredibly special for us to have the international community we have. Just as a brief introduction to us, we're the Oxford Society of Aging and Longevity. We're the Center for Education, Research, and Advocacy for students at the University of Oxford and beyond. We do all sorts of interesting events, some in person, which unfortunately not many of you can come to, but many online. And we're delighted to always have exceptional speakers such as Evelyne. So if you're interested in learning more about longevity or just want to get involved somehow, please, if you're not on our mailing list, join, reach out to me anytime you want. I'll drop my details in the chat. You can always reach out to me on LinkedIn or on email. Always keen to meet other longevity aficionados. And lastly, I'd like to thank our partners for the Oxford Society of Aging and Longevity, NetMind Life, Deep Knowledge Group, and Biogerontology Research Center. They've been incredibly supportive of us as an organization, but this event in particular would not have been possible without the participation of Renji Hospital associated with Shanghai Jiaotong University and the Longevity Education Hub, which Evelyne will probably talk about in her discussion. So that's a bit about us. On to Evelyne. So what I normally do is I read out a biography about our speakers, and with Evelyne, it's a bit tough because her biography is so long and it's so broad, and there's so many incredible things that she's done that I think I'm just going to paraphrase why I think Evelyne is so essential and interesting within the longevity ecosystem. So Evelyne is a practitioner, that is, she works with patients. She's a researcher, that is, she's on the front line of trying to understand the underlying cause of aging, but she's also very involved with the structural, political, public health shaping of longevity as a practice. And why I think that's so important is because, as we know in healthcare, so much of what we do is defined by what we can do in our systems. And without taking a complete holistic approach to how we can not only find the discovery, but create systems that prevent rather than treat diseases, we're not going to make this possible. So Evelyne is involved across the board in the ecosystem to actually not just looking at the research and treating patients, but also looking at how we can work with public health systems to change the way we actually structure our health so that we can deliver all of the incredible benefits of longevity science and medicine. So in terms of understanding what longevity medicine is and speaking on that, there is no better person than Evelyne. I'm delighted to have her here. I think without further ado, I'd like to hand it over to Evelyne so that she could tell us what longevity medicine is anyway, because I think there's a lot of hype, there's a lot of discussion around longevity. It itself is a new word. We're trying to understand what it means, both in the public and on a clinical level. And I think we can all use a bit of help actually defining this term, understanding what the practice means, and also importantly, where it's going. So without further ado, I would like to hand it over to Evelyne. I don't know if you're sharing any slides, Evelyne, but I'm going to stop sharing my screen so that you can, but also you don't have to. I know you can speak forever on the subject. If I can just ask everyone to, just a bit of housekeeping before I hand it over, actually, keep yourselves on mute. If you have any questions for Evelyne, drop them in the chat as the talk is happening. We'll have a Q&A at the end where we'll go through all of the questions and we'll pose them to Evelyne, both live and from the chat itself. So thanks everyone for your helping out with that. So Evelyne, over to you.
All right, thank you so much. Thank you very, very much for this extremely generous introduction. Simon always makes me sound extremely better than I actually am. And it's a really great honor and pleasure to be here with everyone who joined. I see a lot of familiar faces. I see a lot of friends, which makes me extremely happy. I even see Professor Pinkus here, which is a great honor. It's one of my first mentors and a very crucial person in the field right now as well. And without further ado, I would just like to mention that those who know me, they know somebody has to shush me actually to stop talking. So please feel free to do that in form of questions so we can have it more as a discussion rather than just me talking. And I've prepared a few slides. If I may share them, I think it's still disabled, but would love to do that, Simon, if possible.
All right, let's see.
And just for those who are interested, I also have prepared some of examples of clinical cases. So if we have some time at the end, we can go through some of them and also discuss them. So we can really have a little bit of a hands-on experience as well, not only the theoretical part.
All right, Evelyn, you are the host now. Perfect.
Yes, and I can share my screen. Everything works well. So thank you so much. So once again, the topic today is healthy longevity medicine, and I would like to discuss the debate around the definition, maybe a little bit of the transition and evolution of the definition, and where we are heading to, and where are still our hurdles, pitfalls, and maybe to provide, for some of you, this might be new, some of the updates from the front line of longevity medicine being the sick care. So what do we actually do in the sick care setting that already involves longevity medicine, and what are the developments in terms of academic clinical longevity medicine in public hospitals. So, but I would like to still start also maybe with a little promotion of Longevity Medicine Day at ARDD on August 28th this year during the ARDD conference. It will be the first day, the opening day, and it will be a full day. It was for the past 3 years only a half a day. Now it's really a full day. That's why Longevity Medicine Day. And I'm honored to have excellent speakers at the day, and it's really very clinical. So we will be discussing specifically those points that are touching on not only transition and translation of neuroscience to clinics, but actually the management right now of those clinics that are being established, and presenting even some of the clinical data from clinics that have been already dealing with longevity biomarkers. And as every year, I have a co-moderator that I invite, and this year I'm extremely honored to have the editor of Nature Medicine with us, which I think is such an extremely important journal for physicians, and not only, but especially for physicians. And we need those, we need much more of those in the field. Now, I'm always opening my speeches with this slide. It's not that I am just lazy to update, but I just still, until now, I still think it's relevant, and it's bringing a little bit the spirit of longevity medicine, or healthy longevity medicine, as we call it now. You know, in this book, Alice in Wonderland, Alice and the Queen were running very, 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 very fast, and then they stopped, and they were in the same place where they started. And Alice said, well, why did we run so fast? We're in the same place. And then the Queen said, well, if you actually want to move things and you want to advance, you have to run up double as fast. And I feel like Alice, and I think a lot of my physician friends and colleagues and peers feel the same. In the field of longevity medicine, as a physician, you really have to run double as fast, because you have to keep up with all the amazing advancements that the field is making in the research, in the biotech, in the industry, in the public health, in the neurosciences. And at the same time, you have to try to see how you can advance the field. So you have to work on at least trying to plan some case studies and have an outline of at least an optimal randomized controlled trials that you would like to run using biomarkers of healthy aging. with some interventions. So it's difficult, and it also requires a lot of translation from languages that for many physicians are foreign. For example, the language of computational science or the language of AI. A new generation of physicians are growing up with that, but in the medical school until now, it's not exactly a part of the curriculum. Meanwhile, artificial intelligence plays a tremendously important role in longevity medicine, as everywhere right now. But I guess in this specific, hopefully soon to be discipline in medicine, or at least a sub-discipline of internal medicine, AI plays a major role. And as we were trying to give a first definition of this field, we were actually asked, Alex Javonkov was asked by Nature Aging after ERDD in 2020, after specifically the talk of Dr. Kai-Fu Lee, who, for some of you who are following the development of AI, they know that he's, like the godfather of AI in terms of the development and descriptions of artificial intelligence permeation into the society. So when the question came, please define longevity medicine, I was very humbly honored to join and to write this piece, where the definition was as follows. We tried to define longevity medicine as an AI-driven precision medicine, and specifically a branch of that precision medicine that is focused on promoting health span and lifespan with the power, with the drive of AI technology. Clearly, we were, of course, very focused on the fact that artificial intelligence is giving us deep neuronal networks and other types of formulations that we can use to develop biological aging clocks, and also because of all the possibilities of actually analyzing and interpreting multiple multi-set data, which I will talk about in just a moment, using the AI. But we still use the definition with words as precision medicine, which even at that point we didn't really like, because it is associated with something and it's not really a branch of something. It's really something very new. Therefore, a year later, we created, together with Professor Andrea Meyer, Society. We saw the gap and the loop that there is no society that is specifically for physicians, or mainly for physicians and clinicians, that would be developing clinical guidelines and recommendations and quality control points, and would actually define the field as we develop. And so after preparation work, we met in September 2022 in Singapore together with the entire executive committee, and we brainstormed for the entire day and came up with the definition that healthy longevity medicine is a field that is optimizing health span by targeting age-related processes along the lifespan. So as you can see here, we were trying really to encapsulate the main messages. Longevity medicine is optimizing things primarily, and it is focusing on translating geosciences, so age-related processes, mechanisms, along the entire lifespan of a specific person. And the executive committee is, as you might know, combined by people who are very much focused clinically. So all of those people are MDs. That was the requirement, and all of them are focusing on something very important in the area of longevity medicine. So Dr. Meyer with cognition and sarcopenia. Myself, I'm mostly working in the field on crossing of oncology and longevity, but also multimorbidity and differential diagnostics. Professor Pink is focused on mental health and cerebral health, and also healthy aging policy, which is very often, as we know, maybe not that much spoken about, as it is one of the most complex fields in longevity medicine. And then, of course, Professor Barsilite with metformin, TAME, and of course, other targets in the endocrinological field. Professor Kirkland with xenomorphics, senolytics, and Professor Randall with stem cell research. And what is the society trying to do, and why am I mentioning this in combination with now us talking about the definition of the field? It's because I guess the definition will still change. It will develop. It will be modified, especially as we are hopefully gonna work more with other stakeholders, because especially this society has put as one of the main missions that collaboration will be much more developed than we are usually used to from medical societies, simply because this field is fueled by multidisciplinarity and collaborations. But some of the main things that are very much missing in the field are the things that we want to do, and those primarily target guidelines on diagnostics and interventions, safety and efficacy, and guidelines also in terms of quality control for longevity medicine, clinical applications, protocols, etc. And for this also, it's very important to have some sort of certification. Of course, as I mentioned, our dream is to have longevity medicine really being a subdiscipline or a discipline, so that longevity physicians will be able to not only call themselves longevity physicians, but will actually be certified in this. And of course, education. That's one of the main passions for all of us, and some of you might already, that there are opportunities to get CME certified in longevity medicine. For those who are not doctors, they can just be certified without CME, because we don't even need CME, on Longevity Education Hub, and also more and more on other platforms. But what we want to do is, of course, to bring those curricula into med schools, so that the new generation of doctors will have the chance to experience something that we, at least my generation, didn't, which is really having healthy aging, longevity medicine diagnostics, AI, computational science in the field of healthy longevity medicine already implemented in their curriculum, so they can really get out of the med school and bring the field forwards, rather than getting out and just tip-topping and learning it as they are doing. And one of the major developments in that sense, or in this direction, is, I believe, the fact that we are facing now opening of longevity medicine departments or longevity medicine centers in public academic university hospitals, or at least public hospitals. And you can see here that we are creating a network of those hospitals at this moment, and there are 3. And this is Mayo Clinic in the US, Sheba in Israel, and Alexandra Hospital in Singapore, affiliated to NUS. And we are now formulating a more formal way of collaboration, and of course, formulating a network that will then further include new centers that will join, because the more the better. And to standardize our protocols, to standardize our measurements, to standardize our cohorts, in order then to have the data exchange being more feasible, easier, and of course to create more cohorts so that we can actually have better statistical outcomes. And of course, we are writing papers. Actually, right now we are writing one of the first paper on how to open a longevity clinic in a public hospital. So stay tuned. Hopefully it will be out soon. Now, shifting back to longevity medicine definition and cross paths in AI. So clearly longevity medicine is an ongoing learning path. That's why the definition will probably change a lot as we are facing different developments and constant learning and translation in AI. And also at the same time, because the patients, as we know, they are expanding their so-called tertiary digital layer. So some time ago, it would be just almost everybody having an email account, but now everybody has a variety of trackers, monitors, sensors, storage data, basically up to the point that some of the patients can fairly, by themselves, create almost their digital twin. Still not maybe in one center, not in a way that it is all centralized and easy, but they will pinpoint and map themselves in a way that they would they would try to create a digital twin, which is a very valuable thing to do, in my opinion. But the point for physicians and for us being in the field is we really need to know and try to work symbiotically with artificial intelligence to co-create a plan and also to co-develop the plan for patients or individuals. And then, of course, as we are working on population level, public health level, then also for populations, how we can implement that into a very fruitful symbiosis. At this point, I would just like to mention one of the dreams, I think, for us physicians is also that at some point of time, the public health stakeholders, and those would, for me, also include insurances and governments, they would actually realize that prevention programs not only should include early diagnostics and early detection of diseases, but at some point would also include biomarkers of aging. They would also include some of the POC diagnostic and monitoring that the patients can conduct themselves so that they do not cause additional burden on the healthcare system, but at the same time allow to prevent at least some of the early diseases and optimally at some point of time also to mitigate the risks to develop those. And I think we can see in the development of healthy longevity medicine, or in general of the medicine, that especially in the last century, the biggest progresses were made. And the actual acceleration of progress started around the year 2014, 2015, with the development of the first senolytic compounds being up in the trials, microbiome analysis and the connecting of the entire omics for the patients, then further development also of the monitoring and wearables that kind of boomed in the past, let's say 7-8 years. And then the evaluation and better usage of the biobanks, the ones that we are all looking at when we are trying to evaluate data from UK Biobank to healthy cohorts and so on. And of course, clinical trials on geroprotectors started and repurposed potential geroprotectors. Why is that? It's because around the year 2014, 2015, we had the development or the biggest boom of machine learning deep neural networks, the so-called old labor of black box, where we could do something that before was extremely time ineffective and usually not yielding a lot of output. And when we physicians would be looking for some new biomarkers, we would go through all the literature. We would try to go through systematic reviews and to look for something that would be innovative, and then correlate it with the basic characteristics of the patients and the markers that were collected in retrospective studies. Meanwhile, what was possible then with the learning methods and deep neural networks is that we were able to grasp longitudinal retrospective data, even if they had missing points, and a lot of those were, of course, missing, but still we were able to use data that were coming from very different dimensions. So data from the lifestyle, data from the functional measurements, data from the omics, data from the blood tests, data even from the environment. So really epigenetic mapping and anamnesis, right? So we were able to take all of it, this entire mesh, and shift it through the transfer learning and federal learning after deep neural networks, basically to give answers or give predictions that are important for us. This was the beginning of complex biomarkers of aging, of complex age metrics, and especially complex biological aging clocks. Those who actually brought us further forward in the understanding of what biological versus chronological.
Sorry, Evelyne, 1 second. Can everyone please put themselves on mute? There's just a bit of background noise. Thank you, everyone.
Right. And so some of those technologies we know, some of them were very important. I just really would like to mention that deep learning and transfer learning and federal learning played a very important role. But even though those techniques were mostly used, even at that point of time, generative AI was already stepping in. So in order to create a lot of data, even within this framework, a lot of generative AI was already used. And generative AI at that point of time, maybe in a smaller amount, but still was able to give us the opportunity to learn from data of sick patients, then to extract the predictors and the markers that are predicting disease, then go back and learn from the data set, those data sets.
Fa un caldo bestia. Io quando esco dall'ospedale mi fa un caldo. Che vuol dire deep learning?
Approfondimento.
Sorry, Walter, Chiara, if you could please put your mic on mute, that would be great. Thank you so much.
I love that there is a discussion already going, with people. No, I think it's wonderful. Like, what's deep network? Sure, I should have explained that. So deep neuronal networks are basically just algorithms, computational science things that are helping us as a network to make predictions and to combine different data points that are not exactly matching. So like blood and BMI and omics and radiological findings, right? Very, very different meshy data points, such as mentioned here, for example, from EEG to ECG, but basically any clinical measurement that you could imagine, plus questionnaires and stuff like that. All of them put into deep neuronal networks and extracting some of the measurements that we can then use in the clinic. And why am I mentioning generative AI? Because there was, of course, in the past year, I guess it was about a year now, right, from early February, that the discussion came about generative AI entering the clinics with ChatGPT and others. So again, that's not new, but it's good that it's there. And I think there is a safe amount of caution for the physicians to take care of, but at the same time, it's a tremendous opportunity for us, especially in longevity medicine, to create even more data and create more data sets that we can then use further to optimize our especially biological aging clocks, and maybe also other measurements, specifically those biological aging clocks that will target specific organs, and also adjust those biological aging clocks to different ethnicities and to different ages, and also to different cohorts, right? So for example, and I will mention that later on, it's beautiful that we can use already biological aging clocks and also, of course, other measurements of biological age in longevity settings on, for example, cancer patients. It turned out to be extremely helpful. Now I will present you some unpublished data here, but at the same time, I would love to have a biological aging clock specifically trained on cancer patients. I would like to have a cancer aging clock, right? So out of all of that, I think AI, and especially generative AI, can help us a lot in that sense. And there's a very good article that I recommend to read to everybody in Nature Medicine from February 2023, explaining very nicely, step by step, how ChatGPT can work for medical aspects, and what are the benefits and potentials for clinics and physicians, and where are the points where we should be cautious. Bottom line message of that article was, of course, that generative AI can be very helpful for clinicians, but the clinicians have still to be involved. There is a reasonable amount of emotional diagnostic reasoning and also rational diagnostics that, that generative AI is still not able to grasp. And what is also very important for healthy longevity medicine definition is that we are moving towards something very different from the standard reactive medicine, so from treating diseases. And there lies also a difficulty when patients are asking some questions. Very often they refer to what they know, which is the sick care, and nobody is to blame, right? They remember that if I'm sick, I go to the doctor and the doctor treats, or best case scenario, if I want to make sure I'm not sick, I go to the doctor does early prevention, primary prevention, and detects early diseases and treats them earlier so that I have better outcomes. But already at this point, the preventative medicine is actually looking for something that is already there, existent, right? Of course, preventative medicine is of course there to give guidance on how to avoid developing diseases. Absolutely, 100%. But with longevity medicine, we are taking this to a little bit of a different and maybe a little bit higher level, because here we are trying to identify the early risks of that person, even at their optimal performance, at their best risk, at their best health in life, and then to figure out what can we do to mitigate those risks. Where can we target age-related processes so that age-related diseases will not occur, or will not occur as fast, or will not occur in the prevalence that they, that they usually would do. So that's the difference in longevity medicine. And this graph, probably those of you who did the course and maybe who saw some presentations already know. That's why I will briefly go through it, because it is pretty much the quintessence of what we are doing in the clinic. We have the patient journey in the real world, which, as you know, usually commences with pediatrician looking at the frame of the ranges that are normal for the patient, for this child within specific chronological age. That's the standard, and there are guidelines and there are very, very stiff ranges, and that's perfectly fine, right? However, when we are reaching the so-called point of our optimal performance or individual optimal performance, this is usually an interval as well, but it's a very short interval. Individual between 20 and 30 or 30 and 35, depends very much on an individual, but pretty much for everybody, it's somewhere around 20 to 40, and it's usually quite short. And after that, it's a decline. It's a functional decline, it's a general physiological decline, it's an age-related decline that then can come with affiliated comorbidities sooner or later. But still, even during this decline, we are seen by doctors, specialists or internists that still evaluate us within the so-called normal ranges, which were based on randomized controlled trials in cohorts in the past. And at some point of time in our late age, when we are elderly or oldest old, those definitions are also changing now all the time, we might be at such a level of frailty that we're going towards palliative medicine, and also we are going to such an amount of multimorbidity. Yeah, we have so many comorbidities that the doctor's memory will not be sufficient in order to make trajectories between different treatments and to really optimize it in a way that would be optimal for that specific patient. And of course, we are working here in this entire field with chronological age, the age in the passport, the age based on date of birth, if we assume that the patient did not lie about the date of birth. Now, in longevity medicine, it's the shape, the curve of life is similar. However, what we are measuring is a bit different, right? And here comes, of course, at the point of collaboration with different disciplines, including computational science, geroscience, and the usage of biological age. Biological age in a larger sense, of course, is a huge debate, and probably we can debate until tomorrow which biological age we measure, when, at what time, which frequency, which organs, for whom, and so on. Nevertheless, I think we already made a big progress in the fact that we know that it's more beneficial to evaluate the patient by biological age, and not only healthy patients, also sick patients. And we are doing that in a way that we can measure biological age for a specific patient at a specific point of time. Also, with algorithms, we can actually evaluate or predict what would be the optimal biological age of that patient at that specific point of time. And I'm mentioning this specifically and slowly and double, because it's very important to mention the second part of the sentence. It's the individual patient, but at this specific point of time, meaning we have here a beautiful tool that gives us the flexibility to also monitor the patient if there are life events, such as COVID, such as pregnancy, such as tragic or good events in terms that will actually affect the health and physiology. And also because it's important to understand this as a 3D thing. So really at least three-dimensional. It is the time, the point of time. And some of us who are working very extensively on epigenetics will also say that it's also the function of the space, but I will not go there in this lecture.
Neveikia gali būti gal dėl dėkliuko nedaeina kontaktas, kad dėkliukas yra uždėtas, gali ir tai būti.
Sorry, if we can, again, just one more time, make sure we're all on mute. Thank you so much.
Or maybe I should let people talk a little bit. But guys, I'm gonna be a bit quicker now, and then leave the clinical cases as optional later on, so we can actually engage in discussions. But let me talk briefly, at least, about what is being done right now, what can be still done in terms of diagnostics and interventions. That is pretty much the question that is affiliated with definition and is also affiliated with Quo Vadis. Yeah, where are we heading with longevity medicine? And how can we mitigate the frustrations of people who are saying, why are we measuring so much if there is still no interventions, right? That's very important. So as you might know, there are many functional tests, there are many radiological tests, there are many omic tests, and further on that we can already use in terms of longevity medicine diagnostics. There are different points of data that we can measure, and this is just one of the examples from one of the clinics that is measuring at least 150 gigabytes or more of each patient every year. And a very valuable data set for the clinic, because they can feed their AI algorithms based on those to make better predictions and to improve, but at the same time to give a really precise diagnostics for that specific patient. And very often there is the question, should we do a whole genome sequencing? Is it valuable to do the polymorphic genetic risk score? Well, yes, I think for every physician, the more the better, right? We love data. And of course, it's better to have them. If it's absolutely necessary, that pretty much depends on the resources. But
Sorry, guys. Looks like we've got a connection issue with Evelyne. Let's just give her a bit of time.
Forced big diseases, those diseases that will burden by WHO.
All right, looks like we lost Evelyne. Let me give her a quick WhatsApp. She is reconnecting.
And I apologize. I'm in a country where internet is not always stable. Simon, can I
yes,
share the screen?
Let me make you the host. 1 second. There you go.
Thank you so much. Oh, I see some more friends joined. Hi, Manuel. All right. Perfect. So stopped. And again, apologies for that. All right. So polygenic risk scores, especially in terms of targeting those diseases that are on top of the global burden of health, but also pharmacogenomics, very valuable input for clinical guidance of patients who actually have the need to be on medications and will be driven by pharmacogenomic results. But I think the most important in terms of healthy patients being guided by longevity physicians are the trackers, the monitors, the liquid biopsies, and all of the point of care panels that we can get that are very reasonably validated or already fully validated, that can help us and can help the patient to have monitoring basically from 24/7 to punctual ones at different frequency and different granularity. So from CGM to tracking of their actual intermittent fasting, ketone bodies, liquid biopsies in every sense, right? Not only from blood, but also from the urine at the moment, from saliva and so on. And other markers that can then help us, again, researchers, physicians, to at least partially and indirectly track the aging rate of different levels of a person, because we know that aging is not consistent. Aging is different not only within a patient on the organ level, so different organs at a different pace, we know that. Every tissue is aging at a different pace, also cells. However, also within the systematic organ, cell and molecular level, we have different paces overall as organisms. So those and especially those trackers that are targeted at specific systems can help us very much to see where is a problem, who is aging too fast, and which organ is at a higher level of risk of aging faster than the others, and how does this organ then influence other organs. And at the same time, we can also monitor other markers that are potentially not per se related to aging, but flow into algorithms such as body mass, such as muscle mass, such as vital capacity of the lungs, stiffness, and so on. So what I'm trying to say here is that collecting data from those different measurements at a frequency and granularity that we have actually never been able to do before. We were able to measure blood pressure 3 times a day. We were able to measure, some weight, maybe even daily, but we didn't measure visceral fat or body composition every day. We didn't measure our glucose continuity day and night, especially at night. We didn't measure our heart rate variability at night, combined and correlated with oxygenation of the brain. So again, all those things, and then going back to the clinic and combining them with data points using or are using anyway, such as even sensory testing or the brain testing, right, in simple radiological pictures, can give us a much better estimation of an individual aging rate, and then also in a larger sense in populations to give us an understanding of which type of epigenetic influences are causing which kind of damage or causing or giving which type of benefits so that we can learn from it. Another example of clinical precision diagnostic is depicted here. I think I can show it because it's not promotion, it's a public hospital, it's for free. But here we can very easily see that not only is this kind of diagnostic and protocol, let's say a pinpoint, one-time measurement and then see you next year, right? It's a journey. And it's a journey that will evolve together with the patient and will evolve through different areas of longevity. And that would usually start with something that will go around the lifestyle, go around the biological age, and then also the functional testing. But at some point, it will also get to a large level. For example, important specifically also our cognitive health, but then also from the very beginning, stratification into biological sex and also gender, and then further on also, depending on the specific time point, focus on the menopause and the andropause and so on. So this journey is being shaped usually in areas, and then once the entity of a person is being kind of wrapped up and mapped, we can then go to a more system-oriented diagnostic and guide the patient then based on the systems or on the organs, right? So once you have mapped your patient, you have understood where are the main risks, you can go and focus on more deeper things, which then would be system-oriented or tissue-oriented. And again, a lot of data points that we are mining for every patient, and that also include, of course, data that are partially not objective, right? A lot of subjective data points, questionnaires and stuff like that. But of course, we are trying mostly to have quantitative data, objective measurements, even on things that usually we would say are instinctively subjective, such as sleep quality, such as how do you feel, your mood and stuff like that. But I think now with the technology we have, including NLP and others, we can fairly reasonably map that as well. And the doctor will then have at least a tool, probably also AI powered and with great support of AI, but also with a lot of human reasoning, emotional intelligence here, a longevity protocol for diagnosing and monitoring. I do not have interventions in this protocol yet, and again, I will mention this in a moment why, but at least for the longevity protocol in terms of diagnosing and monitoring, we can then have a more structured way where we can say that patient will go according to that plan, allowing a level of flexibility for life events, as I mentioned before, including sickness and stuff like that. But for healthy path, that would be something that the patient could clinch on, and also where senior doctors can delegate to junior doctors to go and further monitor the patient. But I guess for me personally, also every longevity protocol, besides of diagnostic and monitoring, should also allow the patient to be educated. So pinpoint the patient to the right education sources, educate the patient, listen to the patient. Secondly, give the right support, right? We have a lot of technical support right now that is available for longevity, even more than probably there is an underuse of those, unfortunately. And last but not least, embed them in longevity programs that are evolving. Biological age measurements are really detrimental, and we have a variety of biological aging clocks. By far, I'm not mentioning all of them here. As we know, this field is growing. But what is important for all of us is to know that none of them are perfect. And it is very important to consolidate them into some sort of metric that would be interpreted by the physician. For many years, there was a question from mostly patients, but not only, which clock is the best? What should we use? Which one should we use? Which one is the best? And I guess the answer here is, well, all of them. optimally you should take all of them and make the right conclusions from their outputs. But I think those that are nicely validated are the clocks that we all know, the epigenetic clocks, the blood, so hematologic clocks, photo clocks, which are not always very easy to execute, but also valuable. And now we also have behavioral clocks, mind clocks. I'm very excited to see the microbiome clock. I think microbiome plays such a tremendous role that the biological age based on microbiome will be a big benefit. And of course, others such as telomere lengths. But where we are going with it is, of course, how do we track a patient? Where is it helping us, especially in the clinic? And I have to say it helps a lot. It helps a lot. I'm giving this example as one of the best examples to show and to demonstrate that self-treatment by patients is not always leading to an optimization. And another thing that a lot of colleagues in the field are underlining is that a lot of geroprotectors or supplements that we are taking have, they very often, or they might, at least if they are not combined in the right way, they might have antagonistic features and actually cause to side effects, or at least neutralize each other. So it is actually also valuable to pass by somebody who knows how those supplements, or at least on which pathways those supplements would be working, and make sure that they are not antagonistic. And here you can see an example of a patient who actually started off at the biological age of 38, chronologically 40, and then puts himself directly on quite a significant amount of supplements, starting from the typical NAD boosters through some of our repurposed drugs that we know, and then probably a little bit too high amount of some of the supplements for boosting muscle growth, from creatinine through amino acid and BCAAs and so on, and of course, and pretty much all the other senolytic-like supplements, which one by one you would say are absolutely fine, right? But there is something as too much, also in terms of dosage, and antagonistic effect. So actually, just half a year later, biological age got much higher, to 44 biologically, and then despite advice of stopping those supplements and actually changing a little bit of the lifestyle, the patient continued, and biological age grew even further. Now, it's finally went down after stopping the supplement, but it is important to know that not everybody will also respond to the supplements the same way, right? So if somebody had already an underlying problem in some of the organs, such as kidney, an abuse of some of the supplements might cause further damage, or at least further loss of function. And such a longevity plan might look like this, might of course also look much more fancy. And I think most of this work that is being done is by the rational thinking of the physician and bringing all the data together. But a lot of compliance of the patient is also needed, so that you can see here, for example, a good example, happy example of a patient that actually has a history, past medical history of cancer, aggressive cancer, cancer survivor. And this patient was followed with using biological age. This is just one of the markers that we used. So as you can see here, I'm not using individual markers. Very often I'm using complex biological aging clocks. And of course, also the individual biomarkers, because you need them to feed the algorithm, but I am not going only by one points. And that patient actually made good progress and remained biologically at the same age over a span of almost 4 chronological years, right? So this is a very good example of a positive thing. And now a few mentions, if we still have time. I'm talking too long, I'm sorry. I'm gonna stop in a moment. So what I'm also very passionate about, and very good examples that we can see already in different hospitals, is that we can actually use and apply longevity medicine in the sick care. So my day-to-day work looks more like this. So I'm working in the oncological ward and also in the ICU. So that's also a lot of data points. That's also a lot of monitoring, but very, very different type of monitoring. And also a lot of exchange with colleagues. Sometimes it's actually also fun, but usually it's relatively sad. So it's usually the end of life. And at the same time, working in longevity field with all the data that we have, with all the wonderful things that we can do in mitigating the risks, there is a question, how can we combine it? How can we, bridge the gap between them, or how we can have, make sure that there is a traffic back and forth? Because I think longevity medicine is still fueled by sick care. And I hope that vice versa, we can fuel a lot from longevity medicine into the sick care. And I think COVID, with all the darkness that it brought on us, showed us that longevity medicine makes sense, and that longevity medicine can be applied in sick patients. So there were studies that were showing that, for example, people with COVID who had worse outcomes, they actually had already an advanced biological age before the diagnosis. And, this paper you might have all read, cautious advice, right? But in general, the message is people who have some sort of physiological status, they have an increase of biological age, but it can be reversed. So, you recover from COVID and your biological age goes down, and the same after pregnancy or surgery. So here's the paper that we actually published in 2021 based on the cohort of almost 6,000 patients from New York during the COVID time. And as I mentioned, it was very clearly visible that the blood age prediction was giving us a very good prognostic marker for worst outcomes. Increased biological age was combined with much worse outcomes and higher mortality, and especially the increased pace of aging in COVID patients was the biggest predictor for mortality. So again, it's not the actual and only the actual and factual biological age, but the pace of aging. And we've seen also good examples of longevity medicine being implemented in some of the studies in cardiology. This is an overview from the Biomarker Consortium from China, the large paper, which you might have seen. If not, I really recommend it for you. They made a huge analysis on the currently available biomarkers and also biological aging clocks for specific organs. And heart was one of them, of course. And in a study that we did actually in a cohort in Italy, one of the largest cohorts in Europe on chronic heart failure patients, we've seen also that the norms were shifted towards a higher biological age in the patients with chronic heart failure, which is normal logic, yeah, but we confirmed it. But at the same time, we were able also to see which of those parameters that are outside of the algorithm of the biological age can, together with the biological age, give us a better predictor, right? So those measurements, again, the measurements from the bedside, together with the measurements from longevity medicine, can give us a powerful symbiosis and give us much better prediction. And the same you can see here. Again, here's a plot that we've seen in this cohort where the chronological age was, of course, a predictor of worse outcomes, but the biological age was a much better one. And last but not least, the same for oncology. Oncology is, I think, the best example of best discipline, because the pathways of aging are very much correlated with the pathways of oncology and oncogenesis. And here's an analysis from Switzerland that we did, where we looked at the cohort of breast cancer patients. And as you can see here, once again, the biological age of patients was a much stronger predictor of worse prognosis, overall prognosis in cancer patients than the chronological age. Meaning, especially in those old cancer patients, those patients where we do not really have guidelines how to treat them because they are not included in the randomized controlled trials after the age of 60, 65. we have at least some tool right now to stratify them better and to stratify them towards better diagnostics and also towards better treatment. As for now, very often the decision if to make the regimen of the treatment in a lower dose or to stop it or to not to give it at all was driven by tumor board discussions or just one physician's discretion or family decision. Right now, of course, we have very good genetic genotyping and mapping, but at the same time, instead of using those expensive tests, we can also just go and do testing in terms of NLP and biological testing and functional testing and see if that patient has potentially good response with less toxicity in terms of oncological cancer treatment. I never have enough time to talk about cerebral health and cerebral longevity, but targeting neuropsychiatry is extremely important. And one of the markers that we are using is definitely the brain age. For those measurements, we are using, again, algorithms from machine learning that were trained on various biological data sets. But we also have now better and better predictors in terms of mental health. And at the same time, we are seeing relatively fairly good biological age predictions based on the measurements, quantification with MRIs. And last but not least, I think longevity physicians are once again extremely important for the field, and it's important to train them properly, to make them passionate about the field. And Longevity Medicine Education Hub is one of those creations that we did as a team since 2020, where physicians and not only anybody can take a course, but it's 101 to Longevity Medicine 201 for free, completely for free, get certified and learn the basics in a way of a curriculum that is structured and pretty much school-based. Right, at this point, I would like to thank you once again for your patience and for your attention, and I will be extremely happy to answer your questions.
Thank you so much, Evelyne. Also seeing as though it's past midnight in Shanghai, and somehow you have more and more energy as the night goes. I'm gonna ask everyone who has a question to raise their hands. There have been a number of questions in the chat that are really fantastic. I'm gonna start with one, paraphrasing it, and then hand over to some of our things. So, Evelyne, one of the developments in recently is this explosion of understanding around longevity, and lots of people are becoming self-motivated to do the tracking, do the self-care. And a lot of what you discussed is about the clinical application or the guided application of everything that we're discovering in science. However, as we know that there is a huge gap in availability of this type of care, we need more clinicians, we need this to become standardized. In the interim, how should we look at people who want to take a more proactive approach around their longevity, but don't have the benefits of the guidance of a clinician, and who may, it wouldn't be an event today if the name Brian Johnson didn't come up, but who may be looking at all different sources for advice and may see other examples of what other people are doing and try to apply them on themselves. How do you see that, and how should we deal with that as educators, clinicians, etc.?
All right. So thank you for the question. And I see also in the chat so many questions. I love it. Thank you so much. I think and maybe from whoever wants to track him or herself or themselves, they should do that with whatever tools they have on hands. And even if because we do not have enough longevity physicians, we do not have enough physicians who have enough time to really advise the patient on that. Hopefully at some point of time there will be GPs that will have time and the ability to also charge for that, so they can sustain themselves. and help those patients. And if at that point of time, patient will come already with the longitudinal data collected by themselves, that's wonderful. Problematic point is, of course, if that patient does tests that can fall false positive or false negative, especially false positive, and might cause anxiety and might cause further unnecessary testing, right? That can happen. And very often, you know, it is very well announced, but this can happen. And so there is a little bit of a caution, but I think most of those tests are also now more and more regulated. So a doctor would have to prescribe it, right? I'm talking here about some of the liquid biopsies, for example, right? Or some of the DNA traces tests, like for colon cancer and so on. But overall, I think we are at the point, luckily, where a lot of the wearables are fairly inexpensive. And, you know, the tracking bands right now are really affordable, those basic ones, and they do the job. They count the steps and they measure the pulse, and some of them even measure the blood pressure, which I love, which is so important. There are more and more wearables that will allow us also to track CGM inexpensively, and so on. So from my perspective, a big yes. Tracking, monitoring, and creating longitudinal data sets for individuals is very important. And even if at this point of time one doesn't have a physician, maybe later they will. And this is where this data will come into place and will be valuable.
Excellent. Thank you, Evelyne. David, I saw you had a couple of questions, but maybe let's start with one before we hand over to someone else, and then we can come back to some of your other questions.
Thanks very much, Evelyne, for a super presentation. You pointed out that there are different aging signs in numerous different organs. We age in different organs, and the different organs age in different ways. As you've been collecting more data, have you found any indications that some of these causes might be earlier, that there might be some organs where you can see signs of damage earlier? And the harder question is, have you any indications that these earlier things, if we treated them, might prevent aging elsewhere? Because after all, the whole point of what you're talking about is targeting aging-related processes. And if there are 500 different things to target, that's a huge task. But if it turns out that there's 3 or 4 that might have greater systematic significance, that would be fantastic to find out. So is there such an indication yet, or do we need a lot more data and more analysis?
Definitely, we still need much more, but we have good indications. And I love this question, by the way, because is my internet again playing hard?
We can hear you.
We're good.
No, okay, good. It wasn't me. All right. So yes, I think in the research that is being done, especially in terms of AI-based drug development and repurposing, where a lot of samples and data are being also analyzed, we can see that a lot of very subtle age-related organ-specific damage is being there already at an early stage, and usually it starts with fibrosis. So that's why you will see a lot of first, hopefully at some point of time, also drugs targeting aging or drugs for longevity, first targeting fibrosis, such as lung fibrosis, kidney fibrosis, and so on. It's a natural process, and if we can detect this fibrosis faster, and now we can, and then also target it with medication at an early stage, even preventatively, that would be perfect. So the answer is yes, and yes, we can do something against it. What is the problem? Why we still don't, or why is it slow? It's because of the regulatory primarily, right? So trials are slow, and we cannot treat something that is not included in ICD. And so those drugs need to be first developed for an indication, and an indication is a sickness, right? So pulmonary fibrosis, kidney-related fibrosis, and so on. But while we are, for example, treating a patient with kidney fibrosis that is, for example, related to lupus, yeah, we can see a partial rejuvenation of other organs. So this antifibrotic effect will then cause also rejuvenation of other organs. Yeah.
Wow.
So yeah, good future ahead, I think. Yeah.
You're mute, Simone.
Thank you, David. All right. Thanks, Evelyne. Next, I'd like to hand the mic over to Fatas. I'm sorry.
Just Slava.
Slava. Thank you, Slava. I'm going to hand mic over to Slava because you had an interesting question.
Yeah, Evelyne, many thanks for this presentation. I really impressed by the activity in this field, yes, by the society, what is planning to do. But I have two pragmatic questions. We are currently planning to implement a longevity department in our hospital. I'm from Latvia. I previously also discussed the collaboration with your institutions. But the question is how we can implement in the current ICD codes, in the current state of the art, the longevity department that can be as a golden standard, not the state of the art in the current clinical medicine, but the golden standard that can be implemented in each hospital. How do you see the outpatient department, inpatient department, daily inpatient department? How will be the collaboration with some institutions, academic institutions? And the second question that is related to healthy society, longevity society, is that do you plan to work to collaborate with other societies that are related to the, for instance, for the cardiology association, for the endocrinology association, for instance, European or American Association of Endocrinology. So the question is, do you have a plan to create a joint statements or some guidelines in collaboration with some specialists in the current existing fields like cardiology, for instance, just to make sure that we have a standards that can be implemented and that are recommended from current existing societies? Thank you.
Yeah. So first of all, well, great that you are planning to open the more the better, and of course collaborations are very welcome. I never received a message, so please ping me about that. And in terms of collaborations of Healthy Longevity Medicine Society with other societies, yes, it's one of the main missions and goals, because it's necessary, also because we want to, and it will happen as a second step. We're very young, we're just 1 year. Are focusing on two main fields right now, but it is something that we will do, and co-develop guidelines so that they can also make use of the longevity diagnostics and therapeutics, and at the same time that we can also be guided by their needs so that we can adjust our guidelines. But I think in order to do that, we need to come up first with our recommendations. And this is what we will do first on our list. We cannot develop guidelines yet. That requires a different framework. And we are gonna do it in a very, very credible way, but recommendations will be done. There will be a list of recommendations. And once this is, so expert opinion and recommendations. And once this is done, we will then further expand and make tight collaborations with strategic societies, and of course expand the network of public centers that will be working together. And not only, right? I mean, I think especially in longevity medicine, the private sector is a little bit, has a very special role and a very specific role, because they are also mining data, and they've been there before, right? So it's also an invaluable help, and this is also very important then to know how to work together in that field in a way that we can benefit from those insights that we are gaining in our work with patients. I hope it answers the question.
Yes, thank you. No. Of course, it's a huge topic describing what means outpatient department, inpatient department in the clinics. It's really a topic to be discussed later. But if there is some studies or some direction how to exactly start to build it, yes, from scratch, I mean, or based on some existing clinics. For instance, we are trying to do it in the internal medicine clinics, just because it's easy to use it, just because there is an endocrinology department. There is a huge variety of implementation, including nutrition department. So that's why we are planning to do it in the internal medicine part. But who knows? And that's why this question persists, and we do not know exactly how to answer it with the current existing knowledge in the field. Yes. This is the problem.
Right. No, the simple answer here is like, no, there is no guidelines. There is no framework that will tell you how to build it. But there will be the paper that I just mentioned that will describe the work on 3 different continents. And there will be definitely this working group. We should probably announce it rather fast and later, where in this network, those clinics are discussing between themselves how they did it. You know, so we do support each other. It's not like we do something and we don't know. It's the opposite. We are discussing, because some of the things are overlapping: administrative points, data sharing, data confidentiality, and so on. But then, you know, some people went through it, so it's easier. But then you will always have your unique problems that only Latvia has, right? So, and we have the same in our countries. Yeah.
Many thanks. Yeah, for the answer.
Thank you, Evelyne. I'm super conscious of Evelyne's time because it is almost 1 a.m. in Shanghai. Okay, I just want to make sure. All right, we had a couple of questions in the chat just asking Evelyne if you can share the slides.
Oh yeah, sure, of course. Yes, okay. They are.
So if anyone wants the slides, feel free to reach out to me or Evelyne, but Evelyne, you can share them with me and then I can disseminate them, whatever's easiest. We had a question from Thomas on clinics and data in different populations. I was wondering if you wanted to share your question. Thomas Santakilio. I can read out the question. Clinics and data in different populations, is there a process for a clinic to join the network? Okay, I think we lost Thomas. All right, let's move on to David. And again, if you have questions, just raise your hand in the chat. But David, I know that you had several questions. So let's hand it back over to you, David.
Thanks again. So there was lots of good news in your presentation, Evelyne. Lots of things happening. The one thing in your slides doesn't seem to be happening. It's on your chart of the progress in longevity medicine, and that right at the end, there is the TAME trial. And the TAME trial has been looked forward to for 10 years or more. You know, it's such a good idea. Surely it's going to happen. The FDA have approved the idea, but still there is no funding for this trial. So I wonder, have you any insight as to what's holding this up still after all the good things people have said about it?
You just mentioned it, the funding. And I really hope that the funding will be close so that this study can run to the end. It's so extremely important and so tremendously impactful, also by the fact that it is the first drug that was actually approved to be trialed with also this sub-indication. And I think as in unfortunately in many disciplines, the funding is a problem.
But there are reasonably wealthy people who from time to time make donations into this space. So each of them presumably has thought about it, but they have obviously decided it's not a sufficient priority for them. So,
well, I don't know where are the priorities, and you know, people who donate probably they donate out of a good heart, but most of the inputs still for the funds are, you know, coming from sources that request some returns. And metformin is an old drug. It's a very, very cheap drug, extremely cheap drug, right? So maybe that's also one of the problems. Yeah.
thanks.
Thank you so much, David. I think we're almost half an hour past time. So I think that's a wrap for today. Really, thank you everyone who joined the event. Evelyne, thank you so much for your time, this presentation. It's so generous of you.
My pleasure.
Like I said before, if any of you would like to reach out, get more involved in the society, learn more, need access to resources, please feel free to do so. This video has been recorded. We're going to be throwing it up on YouTube, so you'll have access to it later. You can rewatch and share. And yes, we have a couple of people who are DMing me about the copy of the slide. So Evelyne, we'll chat about that offline and make sure people have it. All right, everyone. Thank you so much. Thank you so much. And again, thank you, Evelyne, and onwards and upwards.
Thank you so much. It's so nice.